On today's session. Welcome to our project scope session. If you will go ahead and make sure to put your name and contact information in the chat. If you are on the phone calling in, if you could also make sure that you let us know who you are for our attendance purposes. As always, thank you for joining us today. We are recording this session for education and quality improvement purposes. This will be on our Canvas site and our YouTube page. So if you don't want to be recorded, please disconnect from this session. As always, we are trying to build that community of practice. So please rename your profile by putting your name and your job title or where you work in that we are an interactive community. The presenters, stakeholders, and community members, we want you guys to all reach out to each other. We want this to be engaging and interactive, so please turn on your camera. It helps us as presenters as well as just getting to know who's on the call with us. Here in Project Scope, we do use case narratives to solidify our information. If you've joined a past session, you know how that works. We do small breakouts with those. If you're interested in sharing a case with us, please feel free to reach out at Project Scope and send in a case study. When we're talking at any point in time during our session, please remember to protect any personal information. So avoid using names or identifying situations that would lead somebody to know who we're talking about. If you're unsure, please reach out to one of our hub members. They all have an asterisk in front of their name and they'd be able to answer those questions for you. The key components of an ECHO session is just building that community of practice. We always have a didactic speaker, as well as a case narrative or presentation, and then we do some feedback on that case. We'd love to hear your comments in the chat about a reflection from the session or one thing that you might add to your practice on that. You can always pre-register for any ECHO sessions by reaching out to Project Scope at usu.edu. And then we have a survey that will get sent out at the end of each session. And that's how we send out our certificate for credit of attendance. I'm going to turn it over to Jared to talk about the CMEs.
Thanks, Janel. CME has gone really smoothly with this group for the past couple sessions, so I will keep it brief. Reminder to claim CME credit by midnight tonight. Do not delay, do not let that opportunity pass. Claim by midnight tonight. You will get an email after the session with CME information, all the instructions on how to claim, as well as the information on the code for today, but I will put that in the chat briefly. Today's code is 251195. So again, find that in the chat. Claim by tonight. Look for your email and instructions, and those are the essentials. Thanks, Janel.
Thanks, Jared. We've just really enjoyed partnering up with the University of Utah on their ECHO project within our project scope. Once again, our Canvas and RedCap. So Canvas is the platform that we store all of our information on. If you need access to Canvas, please reach out to Kurt or Project Scope and we will get that out to you. RedCap is the survey data collection. Always check your junk emails if you haven't received a survey at the end of the session. Case studies is really just that valuable way to hear from your colleagues about recommendations, sharing information about real life situations. So please, if you have something or would love to hear and share a case, please think about doing a case study for us. Once again, if you haven't followed us, go ahead and follow us on Facebook or Instagram. We do share information about the sessions. as well as useful tidbits on it. We shared about the medical home portal. If you have not looked at that, Mindy and Dr. Goldman-Luthi have done an amazing job of getting a NAS page on the medical home portal. So I'm really excited today to talk to you guys about a couple of things. We have an amazing presenter today, Heather Sarin from the Utah Women's Newborn Quality Collaborative. And then I'm going to briefly talk to us about developmental monitoring at, so I'm going to pull up my other thing and you would think after a year of being able to share screens, I would share correctly, but I still sometimes mess that up. So I'm going to talk really briefly about celebrating healthy child development. When for you that have been on here, you've all heard that I am the program coordinator of our ECHO networks here at the Institute for Disability Research, Policy and Practice. I get the behind the scenes kind of up and running. I am also our autism specialist in our Northern Utah Early Intervention Program, and I am the Act Early Ambassador to the state of Utah for CDC. I have nothing to disclose at this time. In the next few minutes, I'm hoping that I can embrace and share with you guys the importance of healthy child development, learning about developmental milestones, and then some ways to encourage parent-engaged developmental monitoring within our practices. I love sharing about this topic. I'm passionate about involving parents in the process of celebrating their child's milestones and learning to become more active participants in the ongoing conversation about developmental surveillance and screening. It's really a big passion of mine. As professionals, I know that we all understand the importance of developmental screening to identify at-risk or developmental delays and disabilities. But pause and think for a moment. Do we always take the time to encourage our parents to understand developmental monitoring and track those milestones in between our conversations with them? And when I talk about developmental monitoring, it's an ongoing process. It can be done and celebrated by anybody, whether it's by parents, caregivers, grandparents, neighbors. It's just that really nice way to celebrate those milestones. Developmental screening is that more formal process. It is done using a validated screening tool. It's trained professionals that know how to interpret that. A simple tool that here in the state of Utah we use quite frequently is the ages and stages. It wasn't really recent, but one study, the National Survey of Children's Health, looked at this developmental monitoring and developmental screening and how that impacts early intervention. So it looked at saying that if a family does nothing, no developmental monitoring or screening, only 1% of the children that are at risk then seek out those services. When developmental monitoring is done alone, only 2% of the families get the services. If we do developmental screening, only 3%. However, when we do both parent-engaged developmental monitoring and developmental screening together, 6% of the families that are identified at risk or needing additional assessments get the services and support. So thinking about that and how can we encourage parents to be more active in their understanding of it as we're doing that developmental screening becomes a critical piece on what happens. So prenatal opioid exposure is one of the fastest growing global health problems. However, one of the things is that we don't know the long-term neurological and physical developments. Here in Utah, if we think about that, NAS or NOWS is a qualifying diagnosis for early intervention. We know that the continuation of care in receiving that diagnosis is oftentimes lost in the transfer. So therefore, those families aren't getting the services as early or as quickly as they could. Well, we know that we know that NAS is one of the fastest growing health problems, and we don't know those long-term outcomes. We do know that 1 in 6 children aged 3 through 17 have a developmental delay or disability that impacts their learning. We also are aware that some of the impacts of NAS are those babies may be born preterm, they have poor fetal growth, they may have longer hospital stays. And so if we think about that, maybe they're just not even NAS babies, but some of those preterm, we know that seeking out early intervention makes the bigger impact on that. Some factors that that typically begin within 72 hours after birth are listed here on this slide. And if we all remember from Dr. Smith's presentation, where she mentioned that sometimes those don't come about until later on after they've left the hospital, that really begins to emphasize the importance of helping families and caregivers understand developmental milestones and why monitoring that is important. So milestones are really those things that children can do by certain ages. We see them all the time, and they offer those important clues about our child's developmental health. Sometimes as a parent, just having given birth, my stress level may be up. And so I need some guidance in recognizing what those are and what I should be looking at. As a parent, I know my child best. And so I will be able to help my pediatrician or my healthcare provider understand what's going on with my child when I know what I am supposed to be looking for. The American Academy of Pediatrics, as we all know, recommends developmental screening at well-child visits at 9, 18, 24, or 30 months, and that all children are screened for autism spectrum at 18 and 24 months. But I'm sure if I took a poll right now, we all know or can think about a family and child that missed their screening due to a variety of concerns, whether or not they moved or they just missed that well-child visit. So there's where that screening process and continuing to talk about development becomes a critical piece for all of us, whether we are in the healthcare field, the education, or just as a community member, to continue to normalize that conversation about development. We know that when parents are engaged in our process, we build those stronger connections. We have stronger and more positive interactions, and they're more likely to seek out the services when we do that. It becomes a big piece when the child is already in early intervention, when we notice that something else may be a concern with those children. So as we talked earlier, while we may not know the long-term effects, we do know that sometimes children or toddlers who may have experienced the trauma at birth or some of those possible impacts. It might have a cognitive delay, hyperactivity, impulsivity, aggressiveness, speech and language delays, or poor social engagement. So that's another reason why continuing to talk to parents about development is a critical component of all of our efforts, because maybe as a newborn, the NAS did not impact them, but there might be some long-term deficits or disabilities that we need to look at and make sure that the families are aware of that. And as we continue to talk about the healthy development, it really takes that stigma off the delay, and we can just normalize the conversation of celebrating their milestones and acting early when there is a concern. So the CDC does have some amazing free resources for using and encouraging families to seek out developmental monitoring. They have an app. There's some really cute booklets. There's also some milestone checklists. And so as we think about how we might use those within our everyday practice, some ways to do that is just printing and posting those milestone apps, putting them in exam rooms or sharing them, distributing them to families, using the Learn the Signs, Act Early web buttons on your website to promote that developmental monitoring, helping parents to act on developmental concerns, and also learning more about monitoring child development on our own and sharing those updates with families by completing a training called the Watch Me training that does offer CMUs when you participate in that. So I'm really excited to turn the time over to Heather to talk to us about implicit bias. My last slide does just have some resources that you could look at to find some of those resources. So I'm going to stop sharing and turn it over to Heather. Okay, something's happening with my thing.
Hi, folks. I hope that everyone is doing well. Thank you so much for being here, and I'm really excited today to talk to you about reducing implicit bias. So I want to just share a little bit. Here's kind of what we're going to be talking about today. So I'll let you guys look through those, but talking about implicit bias, and it looks like there's about a third, and a third folks online. So it looks like we've got folks from pediatrics, we've got folks representing home visiting and early intervention. Well, this topic really applies to all of those. So we'll be talking about some strategies to improve and be aware of implicit bias. So I just want to clarify that this is not a session to kind of have a magic wand and I'd love to be, Harry Potter and wave that wand and fix implicit bias, but that's not really the goal. And I'm not here to tell you or your organization how to interact with your patients or clients, but really it's just to start having that conversation. And so I thought it'd be helpful. We all come from different lenses, and I just wanted to share a little bit about the lens that I come from. This is myself and our 15-year-old son. He was adopted between 6 and 7 months from Guatemala. So he's got that nice dark skin, whereas I have to put on sunscreen every 5 minutes. Here he is in the middle, getting ready for quinceañera, looking, you know, like a teenager that's excited to be on a trip. And here he is with his 8th grade graduation. He's now going into 10th grade. So sometimes I get some implicit bias if I am out with him by myself. People will ask me like, are you his teacher? Or you know, they won't make the assumption necessarily that I am his mother, and that's one of the implicit biases that I see. Also, about a month ago, we had an appointment at his pediatrician, and we go into the room, and these are all the pictures that I see. Very non-diverse pictures of babies. And, you know, the Hispanic population is actually the fastest growing population. It's about 16% of all new babies. So again, and his pediatrician is actually Hispanic. And so I chatted with her and I said, hey, your pictures need, you know, a little bit of diversity here. And she said, yes, we are working on that. And we do realize that. So I just want to share that because I think that, again, we all come at things through a different lens. And, you know, you may look at this picture and see one thing, I may see another, but ultimately we all just want those healthy outcomes for children and their families. So a little bit about the Implicit Bias Project. So we have access for clinicians to take an e-learning course. It's called Breaking Through Bias in Maternal Health Care. And we still do have some user licenses. So if you're interested, please let me know. My contact information I will put in the chat. We just recently sent opioid use disorder folders to all the Utah and Wyoming hospitals, and those are resource folders for women and their families to, if they do screen positive for OUD or opioid use disorder or substance use disorder, they provide them with those folders, and we also provided them with naloxone. And a shout out, I saw that Dr. Muniapa is on the line. PARCA, which is an organization up at the University of Utah, they recently did some videos on NOWS. What is NOWS? What do I need to know before I go home from the hospital? And what does DCFS do with opioid use disorder moms and families? And that is out there on our website, those videos. So I will provide those resources to you as well. And we work with the Alliance for Innovation on Maternal Health, and they are the ones that produce various safety bundles. And one of these safety bundles is obstetric care for women with opioid use disorder. So what exactly is implicit bias? Well, the way that the course defines it is actions, behaviors, and judgments that are influenced by stereotypes without our awareness or control. And does anybody know how many neuroscientists estimate the human brain can process, how much they can process pieces of data in a second? Anybody want to unmute or put that in the chat? If not, I'll just tell you, but it is 11 million pieces of data in a second. I know it feels that way sometimes if you're on the internet or whatever, but most individuals are only consciously aware of about 40 pieces of information. And what they found is, especially if you are stressed, so let's say COVID epidemic, it makes it even more difficult and you start to make these snap judgments. I'll talk a little bit later about a recent article. It's quite interesting. It's basically what COVID-19 teaches us about implicit bias in pediatric healthcare. And so it talks a lot about that. And again, it really applies to any of the areas that work with children. So I don't know if you guys have heard any of these common stereotypes. I have an Asian friend, and you know, again, I was doing this the other day to her. I was like, oh, well, you know, it's math, so you can do it. And she just kind of looked at me like, that's not a great stereotype there. Again, I think all of these are stereotypes that we see, and we just have to be aware of them and understand the impact that they have. So why is this important to whether it's pediatrics, home visiting, or early intervention? Well, stigma is a really, what's the word I'm looking for? It's basically a way that people decide not to receive care. In relation to opioid, they decide not to get any help. It's a significant barrier in treatment and overall help, and it relates to educational disparities, all types of socioeconomic and social determinants of health. And as they note in this article, I mean, they talk about how, you know, COVID-19 has been really putting out front and center the racial and ethnic disparities in illness and death. And if there's a family that anticipates that they will have implicit bias, they're less likely to share their symptoms, whether it's with a pediatrician or a home visitor, for example. So it is a very important topic, and I'm excited to talk about it. So here are some of the ground rules that we've done in previous meetings. So I'll let you guys take a look at those and see if there's any other ones that you would like to add. Whoops. And the mouse had a mind of its own there, sorry. All right, so I would like to know, and this can be pediatrics, this can be home visiting, or this could be early intervention. I would like to see some examples of implicit bias that you see. So go ahead and put those in the chat, please. Or feel free to unmute. I'm not seeing any, so we can go ahead and move forward, but we'll talk about some. So there was a recent, actually this one was from 2017. So there was a recent article that was on implicit bias in pediatric academic medicine, and talked about how they are seeing this. And have any of you taken the implicit association test? It's called the IAT. This is one that is produced by Harvard, and they have it, it's free, and they have it in various topics. So it can be specific to race, it can be specific to weight, it can be gender. There's a lot of different topics. So what they did in this particular study was that they had pediatricians to take this IAT and find out what their specific bias was. So here are some of the areas that they decided to help them. So barriers to successful recruitment and retention. So the main one that they found was the lack of mentors and role models. They also found that there were a lack of qualified candidates and not enough financial resources to support those recruitment efforts. Some of the barriers to the retention were the limited access to high quality mentors again, the not opportunities for career advancement, and then not enough programs to enhance that academic productivity. This is a little note here on implicit bias in early intervention, and they're saying that it's not intentional, but it can impact how we judge others based on race, ability, gender, culture, and language. So looking at it from a pregnancy standpoint, there are different areas of the population that are disadvantaged and potentially underserved that potentially people could have implicit bias against. We are familiar, of course, with families with substance use disorder, but it can also be someone who is mentally ill. It could be someone who is overweight. It could be someone who, because of their religion or their level of education, they're all different reasons for that. Could be that there are two moms. It could be that she has a lot of tattoos. It could be a mom that's too young, a mom that's too old, a mom that hasn't finished high school. So again, there's a lot of different biases. So what do we do about all these different areas of implicit bias? Well, according to the article that is specific to the what COVID teaches us about the bias in pediatric healthcare, one on the individual level, they talk a lot about just developing that self-awareness around the biases. They talk about working on this, seeking out emotional regulation training. How can you balance this with their families? They also talk about it on an institutional and organizational level and doing quality improvement, encouraging that patient advocacy and the open communication, and just, again, really focused on that open communication. And then looking at it from an educational level, they talk about doing some training with all employees and reinforcing that as well. There's a campaign by the March of Dimes that's called Beyond Labels, and I would highly suggest this. It's doing your part to reduce stigma. And here are some of the summary things that they are looking at. So using that person-first language, we'll talk a little bit more about that in a minute, making your work a judgment-free zone. So in working with some nurses, they talk about making sure that whatever they say, they can have their door open so that if a patient hears, they are not necessarily, it should be fine for any patient to hear. Just starting those conversations about stigma, sometimes it's a challenge, but I think a lot of people start to open up once you make it okay to do. There is a strategy that is noted in the course, and it's called ALLY, and those are the acronyms, but it's avoiding assumptions, learning about the whole patient, and this could be patient and or parent, listening more than you talk, and then also yielding to the patient by involving them into their care. So words do matter. And if you look at the left-hand side of this, these are some of the areas of stigmatizing language. So historically, sometimes people have said, the drug screen is dirty. They are addicted babies. There's abuse. And then the non-stigmatizing language, which is what we want folks to move to, is on the right-hand side. So again, you want to say the baby's born with an opioid tolerance or opioid exposure, substance use disorder, person in recovery. These, again, they really have a big impact on the patients. So I think now we wanted to open it up to those breakout sessions. And in your breakout session, you will be discussing these 5 questions. And then we will, if we have time at the end, we will do a regroup of those particular questions. So any thoughts or comments? I do see from Mindy, I didn't bring this up earlier, but the Spanish-speaking families may not get time or resources needed. And that is true. I know that they've been working on a lot of iPad translation, the ideal is having clinicians who speak Spanish, but that's not always the case. And I think it's making people culturally sensitive and aware of not just Spanish speaking, but really any diverse group. So, any thoughts? Okay, so I'm guessing, I'm not the technology guru, but I'm guessing at some point someone's going to put us in the breakout rooms, I'm thinking.
So,
But, go
Heather,
ahead. Yeah,
thank you so much for your presentation there.
sure.
We're running around with some technical difficulties here.
Okay,
And so
we can do it as a group if you'd like.
have you stopped sharing your screen? We're just going to see if when you stop sharing, if that allows Janelle to retake the screen. Janelle's looking like that's a no. Okay. So sorry for the technical difficulties. I told the other folks here, I said, when you're not the smartest guy in the room, you learn who that smartest guy is. And he's working on it right now. So we may get to that point. But I think for right now, what we're going to do, because Janelle is totally frozen, she can't even log in to say anything, which is tragic. It would be wonderful if it was me that couldn't say anything. That would work well. But if we can just maybe as a group here,
Sure.
take a look at these. And Heather, since you're these are your questions you're presenting, do you mind facilitating this conversation?
Sure, no problem. We're flexible. We go with the flow, so no problem.
You're great.
So
Thank you.
the first question is share examples of where you've seen implicit bias. We had one example in the chat on Spanish speaking families. Where else do you guys see implicit bias? And feel free to unmute or put it in the chat, whichever one you prefer. Don't make me do Bueller.
That
Anyone
only
out
works
there?
for those of us who are 40 and over.
Okay, I know, sorry. Okay, this is a great one from Darla, that dads won't be participating in sessions. That is very true. That's a really great one. Thank you for sharing that. And I was at a national conference on maternal care, and they did have a couple sessions actually on how to get fathers more involved. So that's good that people are starting to think about that. So thank you. Banu said that people assuming that substance use disorder is a choice. That's a very good one as well. People sometimes think that, you know, well, if you just had better strength or morals, that you would be able to move beyond. And it's like a chronic disease like diabetes or any other chronic disease. Young parents in the child welfare system. That's a good one too. I've had a teen mom say to me, you know, just because I'm a teenager doesn't mean that I'm not going to be a good mom. So thank you for sharing that one.
Well, I'll date myself, but yeah, the way many younger people choose to you know, do tattoos or whatever these days, I'm struggling with that just a little bit, because that's not how I was raised. And so I think I have an implicit bias right off the bat when I see, you know, someone who looks quite different than I do. And so I need to overcome that. And my guess is there are others as well who have sort of that internal knee-jerk reaction. So
thank you for sharing that. I do have a colleague, and some of you may have heard the story, but she went for a doctor's appointment, and she had a rash on her arm, and she had a tattoo on her back. And once the doctor saw the tattoo, he just made the assumption that she used drugs, and so kept asking her, like, are you sure, or do you not, you know? And so she was getting really frustrated because again, he was making that assumption, because obviously if you have tattoos that you use, I mean, that's again a very implicit bias, and just the way people look is always a bias as well. So thank you. Just to kind of expand on the one that Banu put in the chat, do you guys see that? Do you see that kind of mindset where people assume that it could be, you know, any type of substance use disorder or alcohol as well? Like, do you see that where people assume that that's a choice for folks?
Can I play the devil's advocate on that?
Sure.
So ultimately, it is everyone's it's their choice. ultimately, when they first started, you know, when I've got a couple of cousins that keep coming to my mind as we talk about this, their circumstances weren't their choice. Their dad died when they were extremely young. Their mom was left with 6 young kids, and she kind of lost it. You know, she was just not quite there mentally and emotionally to do what she needed to do with these kids. And they turned to friends who had drugs, and they decided ultimately to take the drugs. Once that decision was made, was it then their choice to continue to have that need to you know, get that fix that their bodies desperately craved? No, that wasn't their choice. But if you look at it from both sides, they did make a choice. But unfortunately, that choice they made wasn't the choice that they wanted their body to have to make the rest of their life. Does that make sense? You know, and I think implicit bias is something that we all experience. We all have our own way of thinking. You know, I live in Sarin, Utah, Emory County, woo, very small town. And there are still times when I am talking with somebody and they use a incorrect grammatical error in their speech, and I just want to stop them and say, seriously, where did you go to school? You know, but we all have that. We all have something that drives us crazy about somebody else or another culture or another whatever. And to me, implicit bias is normal. I think it's very normal. Our brains are just doing what our brains do. What we have to work toward then is to not see that as let's try and fix the world, or let's force our opinion or our ideas on other people.
Great. No, I appreciate you sharing that perspective. Thank you so much. And you're right. I mean, people do ultimately at the beginning make those decisions. And, you know, 80% of people who use heroin started on prescription opioids. So it was probably not their intent to move to heroin, but again, that's what led to that. And I know growing up in a small town that it's very challenging and everyone knows everybody, and which is good, and of course bad because everyone knows everyone. So I appreciate the you sharing that as well. And I've got some comments in the chat. And so I'm going to start with Tiffany talking about DCFS workers that are not fighting for reunification. So I don't know if Tiffany, if you're able to unmute, if you want to talk a little bit more about that one. If she is unable to unmute, I know in talking with DCFS that, again, they do struggle with kind of the image of DCFS and what they are focused on. They are very focused on the child and doing what is best for the child. And again, that I know is challenging, I'm sure, for parents as well. Christy brings up patients of other ethnicity feeling entitlement because they are of another race. I heard a story recently where this was very true in a case where a diverse patient came into an office. I think it was, I can't remember if it was prenatal or a pediatrician. And again, the nurse interpreted it as entitlement, but actually when they started actually listening to the patient, they found out that the reason that this patient was doing that was because they felt that there was no other way that they were being heard. They felt that they were invisible, and unless they, you know, kind of came across as entitled, that no one would hear that, yes, you know, you are actually having pain and here's what I need to do. So that's just one scenario that I've seen. I don't know if other people have seen that as well. But thank you, Christy, for sharing that perspective. And then I don't know if Jennifer, if you want to unmute and share yours, but you put some really nice thoughts in the chat.
Yeah, to summarize what I put in the chat, I really struggle when I'm working in our nursery, and we, you know, routinely on sometimes daily, at least weekly basis, have moms come in to deliver after having, used heroin, meth, cocaine, whatever, in the 24 hours prior to delivery. And I recognize when I see that, I kind of like, ugh, I feel angry, and I know that I have bias right off the bat. But then, at least over time, I've recognized that I have that, and I need to put it aside so that I can work with these moms to try to offer their newborn the best care that they can. And that's in engaging the mom and not treating her like a bad person. And that strategy has worked really well to build trust and communication, and hopefully, think of it as a time when moms are more motivated to think about recovery and go into a supportive program and take steps to help them and their baby at the same time. So I try to recognize it when I'm working with our residents and med students. So I can, we all kind of have that cringe, oh, she just, used heroin, and then move past it.
Thank you very much for sharing that and talking about that bias. Just so you know, according to Marcella Smid recently, and her team did a cord study. So basically they worked with 82% of the hospitals throughout Utah, and they studied the cords to see what the actual toxicity is of those cords. And what they found was that 10% of moms who delivered in Utah had some type of substance, and this would be only substances that are picked up in the 3rd trimester. So similar to your bias talking about that, I think a lot of people say, oh, it's not happening in my community, but what we have found is that it definitely is happening, and we're seeing huge increases in meth, up 800% since 2010. 7% of those 10% are opioids, and then we're also seeing marijuana as well. So those are the areas that we're seeing that. Another one brought up, let's see, the next one is talking about, yes, this is an interesting revenue deal. So, and feel free to unmute and talk more, but basically it's saying that people of Medicaid take their kids to the emergency room when it may not be necessary for a cold. And it's a real challenge finding a doctor who takes Medicaid. They're not always available. There could be a large wait list. And driving on the freeway, they used to, I don't know if they have them anymore, but they used to have those signs, those billboards that are like, hey, our wait time is only 12 minutes in the emergency room, kind of encouraging you to go. But we all know that that's not the most efficient use of our healthcare, and that we all end up paying more when people do go to the emergency room. Personally, I think that that's probably an educational factor, and some people just feel like they don't have any other options. But anyone else, feel free to weigh in on that.
Do I have another computer? No. No.
No, you're unmuted.
So then we have from Tiffany, she says to keep, so when she first got involved with DCFS, that was her attitude, that they weren't trying to reunify. And since completing drug court and DCFF, okay, let's try that alphabet again, DCFS case, Division of Child and Family Services case, I have a completely different viewpoint towards them. My DCFS caseworker was amazing and had my son's best interest in mind. She was one of my biggest supporters. And I know that she doesn't have great coverage, but I don't know if there are suggestions or things that you think DCFS could do to kind of help build that trust at all. I don't know if anybody has that ideas. And then we do have a shout out to Tiffany. Oh, go ahead. Sorry.
Oh, I was just going to say, as someone, so I've been very impressed with Tiffany and her experience, because I'm the opposite end of that. As someone who has then had someone else's children been placed into my home, I have seen the heartache and the struggle that comes with that relationship. You know, they don't want to be in the situation that they don't love the position they're in, and they want their children back. And I think one of the things that I felt like was the most helpful, at least that from my perspective anyway, was that I was there to tell the parents every chance we could that we were doing everything we could to help their child be healthy and to be strong, and that we would help them in any way that we could. You know, just to let them know that yes, we were there for the child, probably 98%, you know, but there was that 2% where we could be there to help with the parent if they needed that as well. You know, even if it's just hearing that they're, you know, that we're working toward, you know, helping them get their child back. You know, I think it's such a hard battle that it's like you're walking the edge of a sword, you know, and you don't know which way to go that's going to be the most helpful for anybody, you know, but ultimately I think, you know, all you want is for that child to be happy. And I think that the moms, the birth parents need to hear from the adoptive parents or from DCF that they've got it. You know, you can do this, you can keep going, you can have your child back. You know what I mean? Does that make sense? I feel like I just mumbled all of that out.
No, thank you very much. We appreciate that. Excellent. Well, thank you for sharing some ways that you've seen. And again, folks are saying, you know, really great perspective from parent and placement home. So thanks to both of you. And Kyla is on from DCFS. So thank you, Kyla, and your team for all of your amazing work that you do and all the resources that you provide to families. So speaking of resources, let's talk a little bit about, like, what do you think you can do at your organization to help reduce implicit bias? What are some things ideas that you have, ways that you can start to address this concern?
This is Sue from the Institute. And one thing that we're doing on another project, because sometimes you make errors because it's the issue of you don't know what you don't know. And we actually are going to have a kind of, for a project we're working on, have a cultural consultant help advise us and kind of direct us and educate us and us in reverse to that cultural consultant. So I think it's, you know, one that we have to recognize it. And I wanted to share another thing that the state legislature this year, many of you probably knew that Utah had been identified as an English-only state in its state agencies. And so technically we're only supposed to offer our databases, our information in English. So that there were two legislators that submitted a bill to the legislators this year, which passed. And now Utah is not considered an English-only state. And I think that goes a long way in allowing us to recognize and respect, which I don't think that was really the case before.
Excellent. Thank you for letting us know that. I am seeing too on more campaigns. So there's a campaign with the CDC called Hear Her, and it's basically warning signs for pregnant moms. And they are offering this in Arabic, in Chinese, in Vietnamese. I mean, there's probably 20 different languages that they're doing, which is really impressive because historically, you know, maybe they would have it in Spanish kind of as an afterthought. So it is nice that they are trying to do that outreach. And I don't know if you guys are aware, but, you know, in the Salt Lake City school district, they speak almost 200 languages. There's over 180 languages. So it's a lot. We have a lot of diverse communities to reach out to, not just in Salt Lake County, but statewide as well. So I'd love to talk to some of the other notes in the chat. So thank you so much. Please keep them coming. Julie put in education providers and staff about trauma-informed care and foster friendly. I don't know if you want to talk a little bit about trauma-informed care or ACEs, or if there is a class, Julie, that you found particularly helpful.
Oh, thank you for that offer. You know, there's a lot of information on the American Academy of Pediatrics website, as well as the Intermountain Care Process Model for trauma-informed care and trauma screening that provides a lot of resources. But I think, you know, being aware that patients may come in and seem reactive or defensive, and it may be trauma. And if you keep that calm approach, it really helps. And really using the ACEs model, you know, to help us frame that understanding. And particularly for youth in foster care, how that early trauma has impacted their brain development and the choices that they make, and being able to get them into appropriate treatment that way as well. But just helping staff to understand that so that you don't be reactive back when someone seems defensive. And the child welfare piece is just maybe understanding the child welfare process a little bit and not putting up systematic barriers when issues around guardianship and having documentation can be real challenges, and understand that keeping confidential information confidential and reviewing limits of confidentiality with patients is important. So some of those areas I have found can help reduce our implicit bias and maybe just gain understanding of what that individual is going through.
Thanks for sharing that. I appreciate that. I know that within the state of Utah, at least within our division, everyone did go through trauma-informed care training, which was quite good. And I'm hoping that we're seeing more and more, whether it's clinics or hospitals, that are also incorporating that into their care as well, as well as the foster friendly. So thank you. Debbie brought up having someone talk to our staff about the topic and help make each employee aware that we have implicit bias and don't realize it. Do you want to speak to that anymore, Debbie?
I have had a little bit of implicit bias training now, and I have talked to my supervisor about it, and she is now going to ask to have someone speak at our monthly staff meeting, because I think this is something that, like, we all do without even thinking about it, and we don't realize it. But if we can bring awareness, and, you know, if we can somehow, you know, think each individual staff person think to themselves, okay, just because that family comes from a different, you know, is a minority or comes from a socioeconomic background that's not the same as mine or whatever, try to be aware that, you know, what we think is very often wrong. You know, it's not 100% always wrong, but it's definitely stereotypical, and we should try to get away from thinking that way is all. So I'm really happy that she has arranged to have some additional training for our entire staff, because I think that'll be awesome. So, okay.
Great, thank you. There is a, I don't know if any of you have seen the movie Zootopia, but there is a nice clip, and I will, I can send that to Janel as well. And it's kind of a nice way for folks, if they want to watch that. It's about 20 minutes or so, and it talks all about the implicit bias in that movie. And it, you know, it's through cartoon, so I think that's a nice way that you could, you know, have that discussion at a staff meeting as well. Great. Erin brings up, I think being aware of it is first step, but using correct non-biased language would be baby steps heading in the right direction. And Erin, do you have any ideas on ways to find that non-biased language, or is there a guide that you found that's helpful?
I don't have anything. I think that just, you know, being aware and just knowing what it is. I think that So many times people just, like someone else said, you just don't know what you don't know. So just being aware that it's out there and that you have it, and that you need to just make sure you're keeping yourself in check, so to speak, in how you're speaking to both our families, our other people in the office, just all of the above, just awareness.
Great, thank you. Sarah put a comment about the practice of they should talk to clients, patients, families. If the door is open, it doesn't matter who would hear. It seems like a really good way to encourage compassion. And I have to give credit to Annie Hatch. She's at Central Medical Valley, and the hospital there, and this was her idea, and that's what she really was challenging her staff to do, is like, we can't be, talking about patients behind closed doors. If you're going to say something, say it like you were talking directly to the family. And as you said, it really kind of makes you think more empathetically and compassionately towards those clients or customers as well. I don't know if Sarah, if there's anything else from home visiting perspective that you would like to share on that.
Nothing in particular. A really important piece of home visiting for our home visitors, and probably in other practices too, is reflective supervision for the home visitors, so that they can work through their caseload, go through any, secondhand trauma that they're carrying around, just to prevent burnout. But I think even in those settings, you can talk about any difficulties a family may be facing. But if you think about talking about it with that door open, at least you're using hopefully that person first language. You're coming at it a little more empathetically, thinking of the systems that maybe resulted in the family being in the situation. I think it just encourages, more empathetic thinking. And I think that's a good tool when you're trying to work your anti-implicit bias muscle, because we do all have those biases, but this is a really good practical way, it seems like, to kind of get better at that person first language and thinking empathetically. So I liked it a lot.
Great, thanks, Sarah. And I'm glad you brought up burnout because with COVID-19, a lot of clinicians, if not all clinicians, are really burnout. We were at a staff retreat this morning, and it was in someone's backyard, and we had a stick of butter. Someone had brought some bread, and they had butter, and by the end of the meeting, the butter was just all melted. And I think that's how a lot of clinicians are. Like, there's just nothing left to give, and they're just this puddle of butter. And so it's like, how can we take that pool of butter and try to help reshape and provide them support? And it could be the clinicians, it could be the parents. I mean, there's a lot of burnout parents as well. And so how can you try to provide that support and encouragement for someone, whether it's on your staff or a parent who is burnout, and give them some compassion? So thank you. And don't leave your butter out in the outside if you don't want it to melt. Also, a little note to self. Okay, Mindy mentioned knowing the mom as a person, knowing more about her story goes a long way. Busting the biases, asking open-ended and non-judgmental questions to ask some dialogue started can help. So Mindy, tell us about how you do that successfully.
Mindy had to step off.
Okay. So does anyone have any suggestions on kind of getting to know your families or your patients, building that trust? I think one example that I've heard from clinicians, and the clinicians on the line can speak to this, but there's literally like 182 things that you have to do, and it's a 10-minute visit or whatever it is. And I think it's taking a step back and just, it could be as simple as like, how is your day? I mean, I don't know if when you're going to the grocery store, sometimes the cashier will ask me like, how's your day going? What's going on today? And I just think that's a really, especially in this crazy environment that we're living in, is like just taking a minute to ask people how they are, because maybe nobody's asked them that today. And Debbie brings out reminding others about self-care may help us all from becoming butter. Yes, I agree with that. And I think self-care is so very, very important. So thank you guys for sharing that. So We've talked about some ways to reduce it. What are some of the barriers that you think you would anticipate facing if you did bring this up in your work environment? Debbie brings up about when she works with new families, she tries to ask open-ended questions and really listen to what they tell me and make comments about what they tell me. I don't know if you have any examples of an open-ended question that you would ask, Debbie.
Let's see. I'm kind of put on the spot here real quick. Well, just things like, do you have any new concerns? Like I try to always ask that question regardless of how long I've been working with a family. Try to every visit ask about new concerns, because sometimes things happen from one month to the next, or something comes up that wasn't there before, and they might think it's a little minor thing, but if we talk about it now, maybe it can help keep it from becoming a big thing, you know, eventually. So I try to always ask that question, and then, you know, I kind of just always let them take the lead too. I just ask a question or two and see where the conversation goes. And I just try to really do a lot of listening if I can, and provide feedback, and then how can I help you with that kind of thing, you know, so they think I care, and I do care, but I want them to feel like I care. So, you know, does that explain that enough?
Yes, no, definitely. Thank you.
Okay.
And I think a lot of the populations that, you know, we work with, people don't feel heard. They feel invisible. And so I think just taking a minute to really, you know, ask them. And like you said, you know, do you have any new concerns? Are there any things, you know, what do you think you can do?
I also try to tell them that, you know, they all have my phone number, because I schedule personally my own appointments with everybody. And so they all have my phone number, and I always tell families that they can reach out to me even between appointments if they have questions or concerns or anything they want to talk about. And if it's, you know, something that we need to have a visit sooner, we can, or whatever. But I try to make them feel like, you know, that they have accessibility to me, you know, more than just at that visit time. So.
Great. And then Tressa says, I will try to ask if there's anything we would like to talk about that we haven't talked about. And I think that's a really good one as well. Great. Well, I know that we are nearing our end of time, so I will bring up some more slides. Thank you so much, everyone, for sharing those ideas and discussion. That's really, really helpful. I am glad to share any resources that you guys may need on implicit bias. Like I said, I will also put the link to those videos in the chat as well. Let's look here. So here are some ideas talking about, you know, talking to your staff meetings. I'm sure that most of you probably do surveys with your patients or parents about their experience. A lot of times they will be willing to share as well how their experience is. And then there's a ton of resources. If you haven't already, the IA test, they are working on one for substance use disorder. It's not developed yet, but they're really interesting, because at least on mine, I was like, oh, I'm not biased. I can, and then, you know, you get your results. You're like, okay, I'm really biased on that topic. So it's quite interesting. They're pretty quick. It's been out there for a while. But they are quite interesting just to see what your biases are and to be aware. There's also an implicit bias resource guide out there, and just start having that conversation. I really think that the more that we talk about this, the more it becomes kind of like maternal mental health. It becomes more, or any mental health, more normalized, and people feel comfortable and have that trust to share. So I will turn the time back over to Kurt. Thank you guys so much. It's been an honor to speak with you. And like I said, I'm available to touch base on any resources.
Awesome. Heather, thank you so much. And thanks for being flexible with our technical difficulties. I'm not sure exactly what happened and why it would leave me in charge of this rather than Janelle. But thank you to all those who participated today. As usual, the information, the slides from Heather and the developmental monitoring slides from Janelle will both be on the Canvas site. If you have had problems logging into the Canvas or have yet to receive an invite to the Canvas, please contact me. You can contact me either at my email, which I'll put in the chat. It's kurt.phillips@usu.edu. Try to multitask. I'm not very good at that. There's my email if you have questions or that about the Canvas site. If there's anything else that you need help with, let me know. Please look for that survey coming out through REDCap in the next day or two. Like Janelle said at the beginning, check your spam folder and your junk email folder, as sometimes it ends up there. And please fill that out, because that will help us to be able to not only work on the structure, but also the content of what we put into these sessions. So thank you all so much. Again, a big thank you to Janelle and Heather for presenting. One more plug for case studies. If you have a case study you'd like to talk about and get input from other people, we typically do that after the didactic with the groups, and some really good information comes out of those. So thank you all. Have a wonderful rest of your day.